Maimah, let's start with you. Let's go down the line and kind of, I know you've got everyone has a good story that we asked to speak, but if you can kind of introduce yourself and kind of say the connection of why you're here today in your story.
Hi, I'm Maimah Karmo. As of February, I'm an 18 year survivor of triple negative breast cancer. I was diagnosed at 32 years old, found my tumor at 31, and was told that I was too young to have breast cancer. To wait till I was 40 and or 50.
Who told you that?
My doctors.
Very nice. Okay.
My doctor. So my mom's a nurse, fortunately. She taught me breast exams at 13. So I knew my body enough to push for breast, keep pushing. Doctors dismissed me for almost a year. I kept asking for screening. I finally got mammography, came back clean. And I said, well, it can't see what I can feel, so it must be wrong. And they poo-pooed me, but I still kept pushing until I got a biopsy. And thank God I pushed. If I hadn't pushed, I would have been dead years ago. Mm. And so Tigerlily was born as my living legacy, promise to God to ensure that women who looked like me, who were younger at the time, still young, younger and of color, had access to people that looked like us, people that heard us, and that people that saw that we had special challenges and needs to be fulfilled. And so I'm proud to be alive and doing this work every day. We've grown from a org that I created while in chemotherapy to now a national and global organization. So that's what I do every day. Help women come out of the fire, pull them out alive.
That's a great story.
So I'm Pam Traxel. I'm with the American Cancer Society Cancer Action Network, which is the public policy arm of the Cancer Society. What I do is really work with patients, much like Maimah, and people all across the country to get them to tell their stories to elected officials so that members of Congress and state legislators can really understand what they can do in the fight against cancer. And oftentimes they don't exactly know what that is. So my organization is here to talk to them about the solutions that they can bring to help people live longer and healthier lives with cancer.
Okay.
Hi, I'm Crystal Denlinger. I'm the CEO of the National Comprehensive Cancer Network, or NCCN. Our organization writes clinical practice guidelines in oncology, which are used all over the world to help clinicians, providers, patients, payers, policymakers understand what appropriate cancer care is. I'm also a GI medical oncologist. I still practice Friday mornings, so I'll go home and practice tomorrow morning. I'm also the daughter of a cancer survivor and someone who passed away from metastatic disease, so cancer is personal to me. And we work as someone who has worked both in the clinical space and now as head of NCCN, we work every day to make sure that we are improving and facilitating quality, effective, equitable, and accessible cancer care for everybody.
Maimah, you saw some inequalities, as you mentioned, in the system, and that was in 2006, as I see. What progress have we made since then and in the 18 years since?
We made a lot of progress in terms of, for example, when I first began Tigerlily, no one saw Black-led groups like me. They were like, you're a patient. There's huge groups, ACS, love y'all, love, but we're friends. But they were like, there's all these groups like Komen and ACS, like they got it, don't worry about it, right? But you cannot underestimate the Black patient perspective and the things that I faced as a woman. My genetics, my husband left after I got diagnosed, became a single mom. There were financial challenges. There were so many things that were happening to me that I had to fight for. And as I began the organization, I kept pushing to be heard. Triple negative breast cancer was not even talked about in 2006, and we didn't get treatments targeting TNBC till 2019, right? And so I think that while there's been progress made, that now I'm still alive. I have an organization that's national and growing, and we train Black women all over the country now in the world. But I still hear patients calling me every day saying that I didn't get listened to. I was dismissed. I was delayed to get diagnosed, and they died. One of my good friends, Shantae, found a lump in her breast at 26 years old as a nurse. She's a nurse. And she was dismissed for 6 years until her nipple was bleeding. And now she's metastatic and she will die. And so I keep hearing these stories, as much as we're doing with the cancer rates and getting more screening, better diagnostics, DE&I is a huge focus now. I still keep hearing these stories. So my thing is, how do we partner with Black-led groups to do the work and fund us to get the work done? So I don't keep having to bury friends every single month. I've gone to one funeral a month for the past 9 months. And last weekend I went to a funeral of my girlfriend Sheila, and she was 15 years metastatic, But the treatments are failing Black patients and many patients of all colors, right? But most of us were dying at twice as rate as women who were white. So I think that while there's been progress made within equity, within policy, within partnerships, I think that we really have to invest, be in the community, not only as a transaction, but as a relationship, and make more investments in time with those communities.
Pam, you mentioned education and educating Congress. How's that going?
It's a process.
Right.
It's a process. I mean, I think for us, when we think about the inequities that Maimah talked about, I think one of the things that we realize as the American Cancer Society is that there's so much that Congress can do to help resolve those inequities. And so as I sat and listened to this panel today, and particularly Dr. Carnival and the progress that we made in the moonshot, she's right. There's more that we can do to access screening earlier, right? And there are still barriers to screening despite the passage of the Affordable Care Act. So 2 of our legislative priorities for this Congress are the PSA Screening for Him Act, which will allow men who are at high risk of prostate cancer to have access to $0 cost sharing for PSA screening. Cost is a real barrier in men getting screened. You mentioned your wife nagging you.
Yes.
Yeah, there's a lot of.
So, but if there's a big cost, then a lot of men will say, I'm not going for it.
Cost is a barrier. Think about it. If you had to actually go back to a doctor's office to complete a PSA screening that you didn't want to do in the first place, right? Like, there's a challenge there. The second priority we have is the Medicare Multi-Cancer Early Detection Screening Act. So this is a piece of legislation that will create a pathway for coverage for CMS to look at covering these multi-cancer early detection tests once they've been FDA approved and clinical benefit is shown. This is really leaning into where we see the future of cancer screening going, and allowing Congress to kind of not just talk about innovation, but create pathways for coverage for innovation, so that when these tests are FDA approved and CMS has had their process, that we don't create a disparity in who's able to access those tests.
Crystal, talk about innovation, and how do you keep up with the progress, and how do policymakers keep up now with AI, and Congress is talking about regulating AI, and obviously a lot of things are regulated, but there's concern there about going too far.
Yeah, I think that's a great question. And, as both the head of an organization that writes clinical practice guidelines that are updated in real time, as well as someone who on Friday mornings has to sit in front of the patients that I treat, keeping up with the pace of innovation is always a challenge. We are in an era now, and I was thinking about this coming into the panel. 30 years ago, when my dad was diagnosed with cancer, these innovations didn't exist, right? And now, 30 years later, the way in which he was diagnosed and the treatments that he was offered are completely different. And the doctors that treated him, my colleagues back home, need to be able to know exactly what those innovations are at a moment's notice, whether they be at a community cancer center where I grew up, or at a big academic cancer center where I practice today. And one of the ways that I think we keep up with innovation is through clinical practice guidelines, and utilizing the expertise of those in academia, and making sure that we are thinking about how that evidence fits best into everyday practice. It's a challenge for us at the NCCN. We have a large team of staff at headquarters, as well as over 1,900 member institution experts that work on our clinical practice guidelines. They are updated in real time. We had over 200 updates last year based on the pace of innovation. And I think those guidelines, and having those guidelines easily accessible, usable, and available for our clinicians and for our patients, patient versions of these, so that everyone is aware of what appropriate care should look like, is really important. But it's also a matter of educating the population, educating our policymakers, educating all of the oncology stakeholders that guideline concordant care matters, that it improves outcomes, that guidelines can be very useful in helping to know how to treat someone, but also when to refer someone to maybe a different level of care, or how to incorporate multidisciplinary care or tertiary referral centers in addition to local community care. So I think having resources and knowing where to get the information is really important for everyone involved in the community.
Just to follow up on that, education, this event is about educating people and people watching online and the audience. What are some success stories along those lines to get people past the acronyms to say, okay, listen, you really you need to do X, Y, and Z. Cost obviously is a factor, but what are some success stories that you've seen?
Well, I think just the fact that we have developed the clinical practice guidelines, NCCN's clinical practice guidelines, but other organizations as well. ASCO, the American Society of Clinical Oncology, and others do have clinical practice guidelines. And I think making sure that people are aware of those guidelines. And not only that, we've seen that in people who receive guideline concordant care, that they have better outcomes, there are lower disparities, there are lower costs. And there are better quality of life. So making sure that people are aware of them. We know that over 1.8 million people download our guidelines and use our guidelines. There were 15 million downloads last year. I'm sure that across the other professional organizations, there are a number of downloads and users. And I think making sure that everyone across the entire continuum is aware that there are resources available to help define optimal care, and that those resources are easily available, accessible, and usable to define it is really important.
Pam, as far as Washington's very focused on Washington, but outside the Washington Beltway, have you seen what success at the state level with different programs that maybe Washington could learn from?
Yeah, we've actually seen probably a lot more success at the state level than we have here in Washington. I don't think that's going to come as a surprise to anybody on the room or online. I think that when we think about cancer, we know that nearly 2 million Americans are going to be diagnosed with cancer, and everyone has a cancer experience. And so that translates into state legislators who are really actively thinking about what they can do to improve cancer care. And that starts with making sure people have access to care, like expanding Medicaid in the 10 states that have not yet expanded Medicaid, because starting your healthcare journey with an insurance card is where it begins. But then it's making sure that throughout that journey that patients have access to screening, whether it be making sure that the National Breast and Cervical Cancer Early Detection Program, which is both state and federal dollars that allow uninsured women to be screened, is funded appropriately. It's making sure that patients, once they're diagnosed with cancer, have access to biomarker testing. So ACSCAN is very pleased to lead some work where right now, if we have some governors do their work, we will have had 19 states pass a law to guarantee patients access to biomarker testing. And this is really where I think we share something in common with NCCN in leaning into the science. We all know that biomarker testing is the future of personalized medicine, and making sure that these laws pass so that patients have access is really where it begins.
So you've seen less polarization at the state level? I mean, obviously you still have some fights.
A lot less polarization. If we think about our key federal priorities or state priorities, they are largely bipartisan priorities. If we look at the Medicare Multi-Cancer Early Detection Act, we have enormous bipartisan support for that bill in both the House and the Senate. And there aren't very many bills that look like that. And that's because cancer doesn't care whether you're a Democrat or a Republican. Cancer doesn't even care if you're registered to vote.
Maimah, how do you make the healthcare system more fair? What would you like to either, whether it's legislation or how do you get there?
Well, I think nothing's more powerful than an advocate who knows the facts about cancer, how to advocate for herself, and how, before she gets sick, when to start being an advocate, right? The problem is we start when people have cancer, right? Not when they're in there getting their annual women's visit. So we worked to train Black women across the country, trained about 400 women, Black women last year to become angel advocates. They learned about the importance of biomarker testing, clinical trials, self-advocacy, how to be a badass in healthcare and do the right things, ask the right questions. So if they're empowered to be involved in policy, clinical trials, in the healthcare system, they're now emboldened to go and speak for themselves. And once you realize that you have the power to change your own outcome and someone else's, that power can shift how you engage in these spaces. We've had patients who come to us who say, I wish I found you 6 months before, because I've been so lost, so disempowered. Because we've been trained throughout Tigerlily, we now know how to act. They get to meet people like Pam and people at NCCN and other groups that we bring them together with these partners that make them know that they have the power to change their outcome. And so I think the power is that we have to teach each person that we impact, all of you here, you have the power to change healthcare in a way that's huge. And so using that privilege for power is so important to me, and embodying that in the patients I talk to, that I'm here, but if I have the power to do that work, so can you.
Just to follow up on that, how can healthcare become more human and less transactional?
That's a heavy question.
Yeah.
I mean, I think people have to go back to why they started, right? I mean, why do you all work in healthcare? Because you made an oath to protect people, to keep their hearts beating, to keep them, to see them, to feel them, to hear them. And so I tell doctors that I know that there's a time commitment. You have to be in there 15 minutes and out. You're being tracked by insurance, all of that. But if you treat each person that comes before you like a human being, and you see them and you know their individual needs, that's how you get back to personalized care. It's like, my doctor, when I first met my now doctor, he came in, he was rushing me, and I'm like, can you please stop for a moment? I'm like, what color eyes do I have? They're brown or they're black. I'm like, can you hold me? I'm scared. He was like, I can't. Can I do that? I'm like, I want to be touched and held and talked to like a human being. So I tell doctors, you don't forget why you began this work. Don't forget that I'm not the person before me, not number. I'm Maimah. That person is Sheila or Shantae or Nani. And so when you relate to the patient as a person, and you know that your actions could either continue or end their heartbeats, the way you treat them is different, right? And so getting back to that human-centered care is critically important.
I would add to what Maimah's saying. Like, I oftentimes say to people that, like, well, we can't afford to do this, or it's political. It's so difficult. I'm like, it's not difficult when cancer comes to your own family. And that makes a huge difference. And that's what I say to people. Like, if you haven't had an experience with cancer in your life, you are really, really lucky. I won't review your risks of cancer. You can check out cancer.org, but they're really high. And I think it's different when it's in your family. And that's what I mean, oftentimes when legislators say this can't be a priority for me, I'm like, do you have someone in your family that has cancer? Of course you do. So let's talk about what this means, because that's how you make healthcare more patient-centered.
Yeah, I mean, I don't want anyone to have cancer, but if I could put the fear, the utter terror, the grief, the sadness, all that I've been able to see that you've experienced, Pam, even my body, I never had treatment targeting my cancer because I didn't have treatment for TNBC when I was diagnosed. So I lived in fear for up until like 3 years ago. I was afraid that it was coming from me every day of my life. And I watched my friends who had treatments targeting their cancers dying all the time. And I have a daughter who was 3 when I was diagnosed, and now she's 21. But any little headache, backache, anything, I'm afraid for her. And so I think that if I could bottle up the things that we deal with as cancer patients, and the losses and the hurt and the grief and the passion that comes out of that in a bottle, and say, drink this, people could actually know what it feels like to be in our bodies, they might do more. But I don't want that for anybody else. But until you experience these disparities, and disparity isn't just black or white, it's about people that didn't get the right, offered biomarker testing, or get offered a clinical trial, or who was told that, well, the clinical trial is in New York, and you're living in Baltimore and you don't have a car, right? Like, what are you going to do? Your kid has to eat food. You have to pay the bills, right? So I think unless you understand what people are fighting for, people are texting me now for help. I don't sleep. I'm in the worst state. I'm like, hold on, honey, text this person back. But when you care that much, it just becomes your life, and it's urgent. People are dying every day.
Can I add, when I think about how to make cancer more human, it's to recognize that cancer comes in the context of the whole person. It's not just, this is the diagnosis and these are the biomarkers and this is the treatment and even this is the algorithm of how you do it. It's, what are the health-related social needs that impact this patient's ability to get care? What are the care and support mechanisms that this person has around them? What are the services in the community that might be able to support someone? So it's understanding, as an oncologist, the full ecosystem in which you practice, as well as the full ecosystem in which your patient and their family lives. I can tell you personally, cancer is not just about the person who is diagnosed with it. It's everyone who is impacted by it. And we talked earlier about the tumor microenvironment. There is also this patient microenvironment, right? The environment in which this patient is supported, in which this disease is now entering. And I think as the oncology community, clinicians, everyone who's thinking about this, policymakers, payers, that we need to be respecting the time and the attention that's necessary to address the whole person that's living with the diagnosis and those around it, not just the tumor itself. And I think that's how you make cancer more human, and that's how you make treating people more human. And you establish the trust that you can talk to someone safely. You can talk to your doctor safely about the issues that are arising. Maybe that you don't have a car to get to that clinical trial in New York, or maybe I really am interested in clinical trials, and I will do everything possible because I have a family member who lives in New York who can help me do that. But it's asking the questions on the clinician side. It's also, as patients, recognizing and advocating for all of the components of care that need to be considered. So it's on all sides of the stethoscope, so to speak.
Can I add something quickly? I think
Yeah.
too, people have to feel safe, right? As a Black woman living in this country, I know the things I can't do or wear after dark. When I'm in the car, I don't feel safe. So people to me in uniform, for many of our patients, they don't feel safe with people that are in authority, right? And so when you don't feel safe in your Black body in the world, and now you have a cancer disease in your body that is impacting your determinants of health and how you can keep your kids safe and take care of them, and having to go into a healthcare system where you are, maybe told maybe your pain isn't high enough, maybe you're being hypochondriac, maybe all these things people are being told. So if you're not safe in your body or in the world and in healthcare, then how do you feel safe to even adhere to healthcare? When I was getting my treatment, I had a really bad reaction to one of my treatment medications. And they were like, I called the nurse, and I'd be covered in hives from my scalp to my feet, like scratch itching for, I took like 7-8 Benadryls. And she said, well, nobody else has this side effect. So, I mean, they just keep going. I almost quit treatment. And so if I couldn't call my doctor and say I need help and I was going to not adhere to my treatment, I didn't feel safe within that space to say I need help. Can you help me and get that help? Why would I adhere? Why would I go back for support? And so we have patients who maybe one of my other patients, I know we're coming to time, but she was in treatment and her husband left her. She had 3 kids and she ended up being homeless, living in a car. But she was afraid to ask for help because she might lose her kids.
Oh.
So you have to be able to be safe to say, like, I'm going to you and I feel bad. I don't feel good, not get dismissed. But if you have these needs around your housing, around food, around your job, to your point, the patient is a whole person. So when a patient comes to me and they talk to me, so we're done talking, I want them to go like this, like, I feel good, you got me. And that's how I think healthcare can be more human.
Pam, I want to go down the line for each of you on this. We've got a couple of minutes left, so you can take maybe a minute each. But, we have made progress. I talked to older relatives, and they said when they saw the doctor was smoking. You could smoke on a plane back in the day. So those things obviously don't happen anymore. But so what's something that you're very hopeful about? I want to end on a positive note.
I'm hopeful that maybe we have finally reached a time where maybe members of Congress, maybe not all, but some, have really figured out that one of the most important things we need in order to survive serious illness like cancer is health insurance. And I think we were coming out of the pandemic with record high number of insured Americans, and some of that is being undone through Medicaid unwinding. And we obviously have an upcoming expanded subsidy situation with the Affordable Care Act marketplace plans that's coming up. I think we all really need to think about the fact that when you were little, and I'm going to judge this room for a second, your parents might have taken you to the library to get a library card. And you remember it was really special. Like you had to be like, oh, you have to sign your name on the card. And your parents were like trying to teach you how to do that. So this is where you learn for the very first time that cards have power, right? And now today kids are like credit cards. They think it's like free money, right? But imagine what it's like to be a patient like Maimah's talking about and to realize that you don't have a health insurance card.
Yeah.
You know right away what a difficult situation you're in. So if we are really going to fulfill the American Cancer Society's mission, which is to end cancer as we know it for everyone, then people need to have health insurance to do that. Because I know all of you are sitting in your chairs and at home thinking like, right, I need a card to go do that. We have to make sure that people have access to healthcare in order to even begin any of this journey.
Crystal, something you're hopeful?
I'm really hopeful about a couple of things. One is innovation. Like I said, I've lived in a cancer world personally over 30 years. The innovation, and I also am a recovering clinical trialist in my prior life before coming to NCCN. And it's been amazing to watch the innovation, to watch us go from a field where we just give cytotoxic therapies that are very general and just kill rapidly dividing cells, to now being able to look at a particular patient, look at the particular subtype of the disease that they have, and be able to potentially match a therapy not only to the biology of their disease, but also to their goals of care. And be able to have discussions that bring all of the stakeholders together to the table. The fact that we're having this discussion, it makes me very hopeful. Because when I started in oncology 20 years ago, now I'm dating myself, I don't think there was as many discussions about the future and innovation and how do you bring that innovation to the patient.
Mm-hmm.
It was how does the patient come to the innovation? And so the fact that we are now talking about how to increase access to clinical trials, increase diversity of clinical trial enrollment, lower the barriers to get people to the innovation so that where you live doesn't determine whether you have access to innovation is really important. I'm also really just excited about the fact that we have everyone working towards a similar goal, kind of rowing in the same direction, and really thinking about the patient at the heart of that cancer journey and how do we improve patient-centered care and person-centered care. And that may include patient navigation to help those get through care. It may include addressing not just the cancer diagnosis, but those health-related social needs. It may be educating the community through clinical practice guidelines and educational events, educating the policymakers and making sure that they're aware that policies need to be evergreen to keep up with the innovation that's happening on the science side. So I'm really hopeful. I'm an optimist by nature because I'm an oncologist, but I'm really hopeful. And I've already seen a lot of that progress since my dad was diagnosed, and it's amazing to continue to see that grow and to be a part of it.
Maimah, we've got about a minute left. Something you're hopeful on, looking forward.
In 1 minute?
Yeah, 1 minute. I'm going to hold you to that.
Well, I'm hopeful that when I go into rooms, I'm not the only Black patient in the room, or so often now. Hopeful to see more treatments targeting women's bodies that look like me. We have patients getting involved and enrolled in clinical trials, understanding them. I'm hopeful that Black women know they belong in rooms and their voices are meant to be heard. I'm hopeful that my daughter will never say say the words "I have cancer" because of all that we all do together and individually. I'm hopeful that I use this quote a lot. I say to my patients, "If I am possible, so are you." So that if I can be a patient that began an organization while in treatment with no money and can now have a global organization, that it's possible for many other Black women and other women of color as well. Hopeful for change in this world. Innovation is growing at faster and faster paces. I was in Austin, Texas, talking about the importance of AI and technology and screening detection. And I just know that progress does take time, right? So we're impatient because it's urgent, people are dying. But there has been so much change, and that patients are embedded in everything that's happening in healthcare now. For me, that's a big deal. And I'm looking forward to seeing more of the same.
We've run out of time. Please thank our great panelists. Hey, thanks so much.